All right. So, as I said, I'm Dr. Jennifer Hathaway. I practice in Bryan, Texas. I've been doing sleep dentistry along with general dentistry for the last 4 years with these guys and thoroughly enjoying it, learning a lot. And y'all have joined the greatest group in Texas and in the world in order to be in the forefront of practicing sleep dentistry and helping the world of sleep medicine. So tonight we have got a little bit of housekeeping first. We're going to plan our next CE course will be Thursday, December 4th from 6 to 8 p.m. And we've already got the subject for that, and Dr. Denbar will tell us about that later. Tonight, we're going to focus on high resolution pulse oximetry. Hopefully, you all got a chance to look over the course and maybe print out the pages so you will have some good references and you can make your notes there. It is going to be a very helpful, informative course. If all the rest of you all have what I have, and that's a pile of 10 charts with pulse oxes that I have to read and I don't always understand. So now I have my checklist, so I'll be able to interpret those more confidently is what I'm looking forward to. Because we all want to be sure that these appliances that we've designed and the therapy we're providing is actually helping our patient. So that's going to be, it's going to take a big weight off my shoulders tonight. It's what I'm looking forward to. For those of y'all that are trying to get your CE credits, I highly recommend that you take advantage of the program that we're offering. It's $250 for the rest of the year. So that will include tonight's program and then December's. And that gives you 8 CE hours. It's 250 total for the year. Eric is going to send you all out a quiz and a survey. In order to get credits, you fill them out, send them back. He'll get your payment taken. And then his email, which he's going to post in the chat for y'all, is eric@tx-dss.com. And that way he can help you take care of that. Because if you haven't looked, in order to maintain your diplomate status, you have to have 12 hours a year. So he's going to help us get all of that done so we don't have to keep chasing that around. All right. I've covered all my housekeeping. Eric, do you want to take over?
Sure, sure. I will jump in real quick. So just if you would, if you've already sent in your request for CE, I have that. Um, if you have not completed your survey and quizzes for the previous two study club meetings, uh, I can check but if you know you haven't done it, if you shoot me an email, I'll make sure you get those and we can get you the CE hours. So if the way it works is we pay another company $250 and you get your CE for the entire year. If you've been here for the previous two courses, you're going to get 4 hours for each one, and it's going to end up being a total of 16. But it's still a bargain. So if you only get this one and the next one, that's 8. And we just need to make sure you do the survey and the quizzes. So let me know if you're interested. Shoot me an email, and I can get you set up on that system. And if you haven't done the quizzes and surveys, let me know, and I'll get you those. Okay. So that's to wrap up that part of it. Um, so a few of the offices are not meeting the productivity levels I think that they're interested in getting. And so Dr. Dunbar and I went back to the drawing board and said, what can we do to help those offices kind of step up and actually start producing dental sleep medicine in their practice? And what we came up with was the TDSS Provider Growth Initiative. In it, there's 8 modules that we've already created. The modules are meant to walk you through how you can get up and get busy with this. I'm going to share my screen if you don't mind. I've got a little slideshow here. And so what we've got is a provider growth initiative. And let's see. So the focus is on a path for you to become busy in dental sleep medicine. And what we've sort of measured is it takes about 15 hours a month. And if you'll dedicate 15 hours a month, it'll take a couple of months to get up and going. But you can, with those 15 hours, you can see 5 or 6 patients a month. I would say by month 2, our goal is to get you to 2 active patients. There's a little paradigm shift in the way we're going to approach this. But those modules are meant to really help you work through the process. By month 3 and on, we're hoping that you end up with about 5 patients. And then if you want to spend more than 15 hours, you can. So I think this is going to be something that'll really help those. I think if you're not busy, you know who you are, and you can shoot me a chat, or you know what you can do is shoot me an email at that email address, and I put it in the chat. It's eric@tx-dss.com. In order to do this, I'm only gonna work with 4 offices at a time. So I'll be reaching out to some of the offices tomorrow and next week and see if you're interested. Um, we're going to support you in every step. It will take you through finding the patients, getting them referred over to a medical team that will make sure they come back to you if they're diagnosed properly. We're going to go through how to do presentations and deal with both the pros and cons of sleep apnea. You know, what are the risks of untreated sleep apnea? What are the benefits of getting the treatment? And then we also have a piece of it that's called a proactive approach to VA referrals, and it has worked really well with some of our offices. So we'll go over that one also. And then and I'm not going to just read the slide to you, but basically this is something that I think will be very beneficial. And it doesn't matter if you're credentialed with all the offices or not. You know, if you're not credentialed with all the carriers or not, we're going to walk through how you handle that. The patients that you see are going to be patients that you're going to end up getting back in your office in this process. So we're excited about this, and we think we can help those offices that are not as successful as I think you'd like to be. So if you're interested, let me know. Shoot me an email. Again, I'm going to reach out to the offices I think might be really good candidates for this, but I wanted to make sure you knew about it. So real short slideshow there. As Dr. Hathaway said, we've got the next study club is coming up on December 4th, and it's on complicated cases. This is a great one. Dr. Demar goes through a number of different cases on it. And another thing I wanted to share is if you have questions as you're going through the presentation from Dr. Dembar, if you would put those in the chat, Dr. Dembar is not going to answer them when they occur. He's going to go through his presentation, but we're going to take a moment near the end to do a Q&A on his presentation and make sure that y'all get your questions answered. So without any further time on this, I'm going to go ahead and open up Dr. Dembar's presentation.
Do I need to hit the video?
We got you.
No. Yeah, you can turn yours on. I'm going to turn mine off, and you're live.
Okay, great. Good evening. Welcome. I just got here, had a long day today. Before we even start, I want to go off script for just a couple of things. One, we're by the end of the year, we're going to have myofunctional therapy available through TDSS. I've interviewed a couple of myofunctional therapists. I'm really excited about it. I've got about 10 to 15 patients right now that are waiting for our referral, and it'll all be telemedicine, and it'll be through TDSS. Eric can go over this at a later date for you. As far as oximetry is concerned, I treat patients that come in anywhere upwards of 2 to 3 hour drives to my office. And particularly in some of the cities where the traffic is really bad, having them return the oximeters can be quite challenging. So what I've done is I get these little bubble wrapped envelopes, and we get through FedEx. And when the patient takes the oximeter, we give them the envelope that's bubble wrapped with a FedEx sticker on it already. It costs me right at $30. And what we'll do is just tell the patient to FedEx it 2 days back to me. And it's been very popular. Their patients are very accepting of it. So it's just something you might want to consider depending on where your patients come back, and give them an option versus having to bring it back to your office.
Dr. Dembar, can I ask a question on that?
Yeah.
Are you giving the patients a choice that they can prepay for that with you, or are you just paying for it yourself?
Well, no, they prepay me the $30, and then I pay FedEx at the end of the month with a bill.
Okay.
So it's just a matter of giving them the convenience of it.
Absolutely. That's a great way to go. Thank you.
So today's going to be on high resolution pulse oximetry. It is an easy guide for interpretation. And let's go to Can I control the slides or no, you're going to?
Nope, I
Never mind.
got you.
Okay, so I'll get rid of that. So let's go to the next slide. What we're going to do today is talk about the principle of high resolution pulse oximetry. We're going to kind of the supporting research, it's included in here to some degree, but in the handout that y'all have, you have quite a bit of it. The ability to interpret the key parameters of high resolution pulse oximetry and integrating it into your practice, and how to implement it which into your office with your patients. It's one thing just to have it, but to really understand it and to be able to go ahead and explain it to the patient where they understand it. Actually, also how to use it for titration and monitoring. You went too fast. Go back. I think there was one other I wanted to kind of. Oh, patient education and treatment acceptance is really important. And we'll go over a particular software center, which is fabulous for that. Now we can go on. So really high resolution pulse ox, it's a level 4 2-channel device. It measures high resolution measures at about 1 second or less. A lot of patients are going to come in, they're wearing their Apple Watches, etc. And to a great extent, from everything I've read, they're about 60% accurate. They're not high resolution pulse ox. They're 4% or more. And so, I mean, I tell patients it's great to have it, but it's not the same. It's an easy and inexpensive way to titrate. And what it does is it measures your pulse rate variation. We're going to go over that because virtually no one that I'm aware of, and when I was at the meeting, at the AADSM meeting, you start talking pulse rate variation, and it's kind of like people are looking at you like deer in the headlights. Uh, Also deals with hemoglobin saturation versus ventilation. Let's go to the next one. So really it works on a basis of whether using the infrared light or red light. The infrared oxygenated blood absorbs the infrared light more so than, or the infrared light more so than the red light, and of course vice versa. Deoxygenated blood absorbs more red light. They have the specific algorithms within the oximeter, which will go ahead and kick out the information that, of course, we get to see. But that's essentially how it works. Now, one thing you need to be careful of is that dark-skinned people, you can have more of an error when you're reading things because of the melanin content in the skin and as far as how the light's absorbed. Now, there's a tremendous amount of evidence-based research with this. And I don't want to go, I mean, we can go through all of these, but you've got an awful lot in your handout already. And I'll go over it again later, but in essence, the research has shown that your 3% of, oh, how do you work around well, you just have to keep it in mind that there might be some errors as far as the dark skin is concerned. It may
Dr.
not.
Dunbar, don't answer the questions. Save that for the question and answer, okay?
Okay, great. All right. Your 3% desaturation indices, and there's research to back this up, is a very close approximation to your AHI. The Nonin people wanted, I was acting as their consultant for their development of the software. And that was the one thing that I really wanted. And they provided me with a fair amount of research showing me there is an approximation. Is it as accurate as the HST? No, but it is an approximation with it. Let's go to the next. This is, we have a number of the different, evidence-based research aspects here. We can kind of skim through these as far as, oh, one factor on the evidence-based research, one key thing that I always remember is that on your 4% desaturations, when you're at 12, no, it's your 2% desaturation, when it's less than 12.2 times per hour, effectively there's no disease. So I'm always on a lookout for the 2% desat as to how it compares to that 12.2 events per hour. It's just something you might look up. And there is research to back that up. I think it's Seria's, but I'm not positive. It's in the handout. So what we're looking at here is we're going to look at the CT90. That's the cumulative time below 90%. Now, since I guess I worked upside down for 50 years in dentistry, I do things backwards. It's easier for me to understand. You want to keep a patient above 90% oxygen 99% of the time or more. True, the CT90 is just the opposite, but for my simple, easy explanation to the patients and for my understanding, I like to just keep in mind that you want to be above 90% oxygen. You want to be above 90% oxygen 99% of the time or more. SpO2 is the amount of oxygen that your blood's carrying as a percentage of the maximum it could carry. When you read the research, you're dealing with an AHI and you're also dealing with the oxygen saturation. A lot of the research, or some of the research I've read, shows that the SpO2 levels are actually more important than an AHI or an RDI number. It's that oxygen level that makes a difference. Nadir is the lowest oxygen percentage a patient drops to. I've treated patients that drop down into the low 40% range. Go ahead, next one. In your desaturation indices, you go with the 2, 3, and 4%. 3% is an approximation of the AHI. The other two biggies that I've looked at, and I really started doing this just several years ago, is the pulse rate and the pulse rate variation. It's a change in the pulse rate while you're asleep and also what your resting pulse rate is. We'll go over later, but when you have a patient who's asleep and their pulse rate's from 90 to 120, that's not normal. Or you'll have a patient within 10, 15, 30 seconds, pulse rate changes 10 to 20 to 30 points. That's not normal. So we can go to the next. So we're looking at different impactful issues. And this is where with what we're talking about, there's so much bleeding into the airway as far as nasal breathing, mouth breathing. There's so many different head position, etc. And so when you're looking at a pulse rate situation, if a patient is an obligate nasal breather, nasal breathing, if you put your hand on your chest and a hand on your stomach and you breathe through your nose, your belly's going to move. If you breathe through your mouth, your chest is going to move. Well, nasal breathing, diaphragmatic, stimulates the parasympathetic system. So you're going to have less anxiety, less, your breathing, pulse rate, etc. Mouth breathing, you're going to go ahead, since it's chest breathing, you're stimulating the sympathetic system, you're getting less oxygen, etc. So that's going to be impactful for, to some degree, your CT90 and also your pulse rate and pulse rate variation. When I'm looking at things, basically everything is a puzzle. Just think of a big circle and weight, mouth breathing, nasal breathing, tongue position, head position, dental condition, all these things add a piece of the puzzle or a piece of the pie, whatever you want to call it, to the end result. Your resting tongue level, it's going to denote mouth breathing, impact on titration. If you have a low tongue level, it's down and posterior in the mouth. If you have a normal resting tongue level, it's up at the top of your mouth. So of course you're going to have to move the jaw farther forward with a low resting tongue level than you would otherwise. This is where we get a bleed in from myofunctional therapy. Here again, with nasal stuffiness, you're going to get with mouth breathing, you get nasal stuffiness. With nasal breathing, you don't. If anyone has a question later, I'm happy to explain why that occurs. Resting pulse rate, I had a good conversation with Dr. Lou, who's head of cardiology at Seton Hospital Systems here in Austin. And I was telling him how high level or a high pulse rate variation and pulse rate. I'm seeing this in patients, and he just started laughing. He just goes, "Well, Martin, these are all going to be AFib cases down the road, WMI patients." So there is a direct correlation there. When you're looking at the CT90, and I'll show you on some of the examples here. I just had a patient in the mid 80s. When you have low oxygen level in the body, you need more red blood cells. You're going to have an increase in hematocrit. I mean, some of these people, you think they're living at 10,000 feet. With an increase in hematocrit, you're going to have more red blood cells. More red blood cells means you're going to have thicker blood. Then you compare that with your C-reactive protein, CRP. Research has shown that when you have apnea, you have a higher CRP. When you have a higher CRP, the natural reaction to the body is an increase in body inflammation. which subtly increases blood viscosity. So if you got more red blood cells, you got an increase in blood viscosity, you have a higher stroke risk.
Dr. D, go back to that first topic. You kind of jumped through that one real quick and talk about the tongue tie.
Oh, okay. If the tongue, number one, I'll just throw this in. It's a little bit off, but you don't, in my opinion, you never do a frenectomy on a tongue-tied person unless they're going to do myofunctional therapy. If you do, now you just relax the hypotonic genioglossus to drift farther back in the mouth, which is not what you want. So if a tongue is tied, and of course, I've got information on how to look for that, etc. If the tongue is down in the bottom of the mouth, many times it's due to a tongue tie, the lingual frenum. The lingual frenum does not stretch, by the way, because it's a type 1 collagen material. But the tongue tie with a low tongue level, it's down and posterior in your bite, which is pushing the tongue back to the posterior airway space. When that occurs, you're going to have to move your tongue, your jaw forward farther than normal to get the tongue out of the airway. Because remember, all an oral appliance is doing is simulating this CPR move with a mechanical device. And when you're looking at a low tongue level, particularly tongue-tied, and you deal with Pasculi's law, in essence, that states that any movement of the lower jaw impacts the airway to the fourth power. We'll kind of go over that a little later. So a quarter, a half a millimeter movement is major as far as airway, since you're looking at the fourth power. So issue, a tongue tie issue can impact your advancement significantly. We can go to the next, unless you want more.
No, I was going to give you a comment. We have a group of ear, nose, and throat surgeons here that do not like people doing frenectomies, but they don't ever address the reason you just spoke about. So that is very important. And the fact that we're going to have the myofunctional therapist to work with our group is going to really turn that around for people.
Oh, I'm excited about that too, because it's going to be a win-win for the office that refers and the patient that is being treated. When you're looking at oximeters or sleep studies, you always have night-to-night variability. I've had patients one night on a home sleep test have an HI of 2, and on the next night for a two-night test, it'd be 22. Or one night had an HI of 11, and the next night 44. You've got to realize that any home oximeter test, HST is one night out of the patient's life. I always tell patients this. I say, look, if you look like a duck, walk like a duck, you're a duck. You fit all the aspects of a duck with apnea. We just don't know how big a duck you are. Some nights you're a big duck, some nights you're a small duck. So with night-to-night variability, you have to always consider that with what you're getting or what you're seeing in the patient's history. So the next thing is your oxygen level and homocysteine. The two world leading experts on homocysteine, it's a husband and wife team, the Levies out of Israel. They call individuals that reach to age 50, I think they're over dramatic, but with a high homocysteine level, they call them survivors. Homocysteine is a free radical amino acid. Everyone's taking vitamins to get rid of free radicals. And so when you have a low or except when you desaturate, which is SpO2, when you basically have a low oxygen level, you get hyperhomocysteine. Homocysteine levels increase. When you have increased homocysteine levels, it causes oxidation in the blood vessels, allowing for cholesterol to settle, coronary artery disease. So in essence, when you're dealing with it's funny, I always tell patients, when you go in for your physical, ask them to do a homocysteine test, but don't tell them I told you, because I've actually told patients to do it or said you might recommend it. And then the physician goes, well, who told you to do that? And then when they go, my dentist, Dr. Denbar, of course, they then say, tell them to stay the hell out of our business. So the point is, when a person is being seen, you might want to ask them to do the homocysteine levels. Hyperhomocystinemia is endemically diagnostic for sleep apnea. Now, there are homocysteine vitamins that are available, life extension. This isn't in the handout. I'm kind of going off script, but you might write down life extension vitamins. They have homocysteine vitamins, anti-homocysteine vitamins. It's an elevated level of B6, B12, and folic acid. And when you have proper levels of B6, B12, and folic acid, that interacts with homocysteine to form protein building blocks. So you're not dealing with a hyperhomocysteine level aspect. Celebrex, it increases coagulation. So you take a patient with a high CRP, C-reactive protein, they got low oxygen levels, then you throw in factor V Leiden, which is in essence increases the chance for deep vein thrombosis, DVTs. Factor V Leiden is a genetic situation that causes clots to form, particularly DVTs, due to the fact of lack of nitric oxide. Its apnea impacts nitric oxide levels, which at the same time can increase clotting factors, which of course with factor V Leiden, it's throwing gas on the fire. I would highly recommend everyone put on your medical history factor V Leiden. I would also recommend you put Ehlers-Danlos too. It's a connective tissue disorder. They're very highly predisposed to sleep apnea. And then, of course, you're going to have an increased incidence of TIA if you're taking Celebrex. Just kind of for clarification, I know you told me twice only, Eric, but I'll throw this out. I've been in the field 31 years. I've had a 45-year-old patient, 49-year-old patient, Mr. Eads, and he told his wife said I could use his name, Robert Eads. Great guy. He didn't really think that wearing appliance was that important. And he didn't wear it one night, fell asleep in his office chair, and he died. And it was very hard talking to a widow. And I went to both, I sent his autopsy reports to both the Texas and Baylor medical schools, and they said it was apnea. Now, he had not really bad, but he had epilepsy. And this is where you get SUDEP, sudden unexpected death from epilepsy. So when you're looking at your medical history, anyone with epilepsy, Ehlers-Danlos, factor V Leiden, to me, that's an automatic, I'd send him home with an oximeter or I'd send him in for an evaluation by a physician because those are they have a high preponderance of sleep apnea potential. The the Bohr effect is, I'm not sure how many of y'all have heard of it, but it was developed by Christian Bohr in 1904. His son, maybe some of y'all have heard of Neil Bohr, the famous physicist. And what the Bohr effect states is that in order to get oxygen from the atmosphere, you need a blood pH of 7.45 to get into the tissue, into the lungs, the red blood cells. In order to have the red blood cells release the oxygen into the body, the muscles, the brain, you need a blood pH of 7.35. This is where mouth breathing comes in because you need to keep a residual of CO2, 6.5% CO2 in the lungs. If you're mouth breathing and blowing off CO2 like crazy, all right, or even just in general, what's going to happen is the oxygen will not break off the red blood cell, so it simply just circulates in the body. And of course, now you're looking at lack of oxygen, your SpO2. So the Bohr effect, it's nice in my mind, it's nice to know behind the scenes of what's going on. Next. Now the medical legal issues. This is very controversial. I can give you my 3 cents worth after being in the field 31 years. I've been sued. I've been taken to the state board. Keith Thornton and I brought this whole field to Texas back in the mid 90s to early. He was about a year and a half ahead of me. So I've got a tremendous number of arrows in my back, and I've researched everything to a great extent. For dentists to bill for a home sleep test. I had a patient a number of years ago. He was one of the senior medical directors for United Health. And he's sitting in the chair, and I just said, well, let me ask you, sir, if I went ahead and ordered a treadmill, what would you say? And he just started laughing. He go, what are you, crazy? And I said, well, that's fine. That's a medical test. What if I ordered a home sleep test? And he goes, that's a good question. He said, what dentists don't realize is that if you're billing, when you bill for a home sleep test, it is electronically approved. But then when they go back and they do an actual audit with the person reviewing it, uh, they're not going to pay for it. Actually, I worked with the Academy of Dental Sleep Medicine a long time ago. They had an insurance rep, and this was in California at the time. Dentists were billing like crazy for it, and they told me that actually they went in and got refunds upwards into the high six figures from the dentists. So I would not recommend anyone to bill for it. That's in the physician's realm. Diagnosing, and here again, I'm very conservative. I don't know if any of y'all know Ken Burley. He's a litigation attorney, a dentist. He's also a diplomat. Is very well known in the field of dental sleep medicine. And this is my viewpoint because of what's happened to me over the last 30 plus years. Is that if you do, and I used to have two apnea links when home about 10 years ago, and I gave them to a physician. Are you telling me to drop that and go to the next one?
No, it just changed something while I was resetting the gallery. Sorry.
Oh, okay. No, that's a problem.
Keep
No
going.
problem. So if you do, a lot of dentists say, well, I just titrate with a home sleep test. I've had patients over the years where, now mind you, I'll give them the appliance and they go, uh, oh my God, I feel great. You do a home sleep test on them and they're not quite right, but they go, it's okay, doc. And you never see them again. And then 3, 4 months later, a year later, they haven't gone to see anybody. The only last diagnostic test and it's not that you gave the diagnosis, but it's a test that can derive a diagnosis, uh, was you. And say they run into a church bus, they fall asleep and get killed. Well, this is where you're now dealing with litigation and you're in the courtroom. And I'll never forget Ken Burley said, Martin, you got to realize a lot of what's going on now in our field has not been determined. It'll be determined in the court of law by a jury of your peers. And I just love Ken because he goes, now, Martin, you go over to the Walmart parking lot, sit in the parking lot and see your jury of peers. So since a 3% DSAC can give me an approximation of that, I generally don't even bother with home sleep tests. That's all in the physician's realm. From a financial impact aspect, physicians do bill for this. It's a part of their revenue stream. So when I'm doing with their norm, and I'm say you're not charging for it, but when you're doing something and you send it to them, you've cut them out of a revenue stream. I've had physicians come up to me at a Christmas party, not very happy with hearing about some of the things that, as far as revenue streams, impacted for their practice by what dentists are doing. So that's just the politics of this. Now, if you're going to do home sleep tests out of your office, say Dr. Jones wants you to do it, get him to write you a blanket prescription just on one of his prescriptions pads and just say, ordering Dr. So-and-so to do HSTs for me for my patients. Now you're working under his orders. Boom. I wouldn't bill for it, but from a medical legal aspect, you're working under his prescription and his order. Let's go with the next. To a great degree, this is what we were just talking about. Don't recommend billing for dental sleep medicine or for the home sleep testing. Now, when you're looking at this, there are dentists out there, and I think they're well-meaning, but I don't think they really understand what's going on. I know some dentists here in Austin. What they'll do, they'll see a patient in their through hygiene and say, "Oh, I think you have sleep apnea." They go ahead and order a home sleep test through a service, and the patient has a home sleep test. The physician does the home sleep test, writes a script, and then the dentist goes and treats. Well, you're practicing medicine without a license. If you read the State Board of Medical Rules, that patient has to be seen for a face-to-face evaluation by a physician to determine if that patient needs a home sleep test or a diagnostic test. When the diagnostic test is done, then that physician has to go ahead and explain it or have a post-following appointment. And these are all the progress notes pre-test, the test, and then post-test progress notes by the physician. And this is important if you're going to be submitting insurance because every one of the insurance carriers demand it. Now, the difference is some will want to review it and others are going to trust you until you're audited. So that's the medical legal issues here with this. Let's go to the next one.
Speak a little bit to the fact that by following these steps and using the software and the SOAP notes, what that does to help build your practice.
Well, here again, this is the field of sleep is very small, and it's not a lot of doctors doing it or wanting to do it. And so what's really important is for you to follow a particular standard of care, putting you at a very high level. And I'm not expecting a lot of y'all that are starting to do this to follow everything. And this is where Eric and I are here to support y'all however we can. But you want to follow the normal paradigm. You want to be able to have with your electronic medical record proper follow-up notes, proper SOAP notes. This is how physicians communicate between each other. I've heard from so many physicians that they'll refer a patient to a dentist and then they never hear from them. No progress notes, no SOAP note. They have no clue whatever happened to their patient. So this is really how you build your practice through providing appropriate service or patient care at the level they're used to. Does that answer for you, Jennifer?
Yes, sir. Thank you.
This is, I think we've already gone over this as far as being the last provider of or last doctor of record for a diagnostic test per se. Now, some dentists, totally disagree with me, and you're more than welcome to. But considering I've been sued twice now, each time one I had about 150 pages of records when you accumulated everything. Uh, they didn't even once I sent my records over to them, they just nothing went beyond that point. And this is, what you're dealing with in the medical world. The financial impact of referral sources, there was a company out there that used the term mining for patients. And I thought about this a lot. And a lot of practices have very large or a large number of patients. And of course, you're looking at when you review through hygiene, you review your medical history, 50% of diabetics, 50% of depressives, 35% of obesity, blood pressure, two meds, 70%, et cetera. You've got a wealth of patient base to even start with. And then we've been able to provide a wonderful physician group that's all telemedicine, that's very conducive to oral appliances, very conducive to combination therapy. I've given an in-service to, I think there are 8 to 10 physicians. So it's not like you're going to send the patient off, and I know this has happened to many of y'all where you never see them again. Oh, we just sent them off for CPAP. That doesn't happen with this group. So the financial impact with this is that it's big time for your practice. And secondly, when you start doing these little things for your patients, they start looking at you as a more of a holistic doctor. They're looking at you more of an overcaring scenario situation. And this can be done all through the hygiene department. When your patient's got your mouth open and your hygienist is doing her thing, she can be talking about myofunctional therapy, about, your husband snoring, or you're complaining you're going to the bathroom 3 or 4 times a night. You can ask them about the kids. Is there ADD? I mean, there's such a wealth of productive capability that you have in the position and you are in with your practice along with your team. Let's go to the next one. Oh, you went back. Got to go forward.
I think you covered the HSTs.
Yeah. So everyone has a different opinion on what high resolution pulse oximeter to use. I have 15 3150s in the office. I replaced my 3100s with a 3150. They're fabulous. They're comfortable. They're wrist worn. Um, and I just love them. They're tough as can be. I've finally, after 10 years, I think I bought 10 new ones last year, but those lasted me for upwards of 10 years. The only real expense is replacing the battery as such. And I bill out on a cash basis, I bill $55 for them. Some of the policies and Medicare, that's a cash item. When you start billing for it, some policies don't pay for it. Some will give you $10. It just depends, but it is a very valid, clean dollar bill. You're doing a wonderful service, and I love that. Known at 3150. The software, the ProFox, I've had the ProFox in my office for 25 years. It is fabulous. It is user-friendly, clear, excellent patient education tools. And what's really good with this, it's one thing to be able to say, well, your oximeter report shows this. And they go, well, I got my oximeter. I've got the Apple Watch and I can look at all that. And I go, yes, I know, but it doesn't break it down like this. And I'll show you later how that occurs. And it really displays the heart rate and heart rate variability. On most all software programs, it'll give you a high pulse rate, a low pulse rate, and a medium pulse rate. And then you're there having to go ahead and read the hypnogram. The Profox breaks it all out. And when you show a patient they've stopped breathing for 2 minutes and 54 seconds, let me tell you, you don't need, it's not that you're selling a case. You don't have to really work hard for case acceptance. And this is what I was talking about with consultations. When you're reviewing oximetry, you can have a normal CT with an elevated desaturation indices and a normal pulse rate and pulse rate variation. We're going to go through all these with the samples, and all the samples I'm providing you are from my patients. You can have an abnormal CT with a normal pulse rate variation, and normal desaturations. And then you can have everything normal, but with a high pulse rate and pulse rate variation. So it's really a mixture and mixing things up, mixing and matching. There we go. I got it out. Now, everyone, there are over 150 appliances out there. I think most of y'all know I'm a TAP guy, Thornton Adjustable Positioner. I started with that appliance back in 95. Actually, I had to go to the hardware store one day before I saw a patient to go buy some nuts and bolts. But the point is, there's a reason for this. I'd say about 4 or 5 years ago, I had the deputy commanding officer for Fort Hood's dental division moonlight out of my office for a year. And I showed him how with one patient, I changed I moved the patient one turn, a quarter of a millimeter, and I showed him on the oximeter report how it changed his SpO2 10%. He couldn't believe it. It doesn't happen all the time. Half a millimeter movements are massive because you're dealing with the fourth power. But I do have enough patients where a quarter millimeter movement can change pulse rate variation, DSATs, all of it. So I don't use any appliances that can't go below they can't go to below a half a millimeter. I just had a case in today. The lady's using, we put her in an EMA with a triple laminate. Those are half a millimeter movements. That's my secondary appliance, but it is what it is. So when you're using titration or your oximeter report, it's really important on referral sources. When you come across a patient and you can't get them quite right, or you're dealing with a low CT90 or elevated pulse rate, I always send a progress note with the oximeter report. This way you're validating your comment to the physician in a very professional way. They can see it. Many times I'll just circle the different abnormalities so they can just kind of hone in and go right to it because they're very busy too. So that's how I use that when dealing with a referring situation. And most of that is when I'm going from regular treatment to combination therapy using the interface. As an example, I've already done 5 or 6 combo cases this month. All right. And from a financial aspect, we recommend $1,400 per case. So I've already done nearly $10,000 in production just on combo cases. Go ahead, next one. So we're going to go ahead and start with the Profox here. This is kind of a summary of the different graphs and results that they show you. I don't use all of them, but I thought we'd just put them up here and you can see them, and I'll tell you the ones that I do and don't use. So let's go to the next one here. This is, I wish we could have made these bigger so that you could see it easier. Get a magnifying glass if it helps. This on the Profox, this page will have the hypnogram on it, but really what you're looking at is the SpO2. the pulse graph, the pulse graphs. If you look at this patient, and we're going to go systematically with all these different cases I'm showing you so that you have a good systematic aspect to look at. But here again, in this patient, all right, they're below 90% for 53 minutes. Oh, wait, 16% of the time, 53 minutes and 36 seconds. One thing that I think y'all might want to do is hook yourself up, put on your oximeter, put it on your finger, hold your breath as long as you can. I challenge anyone, unless you're a marathon runner or you live in Colorado, to get below oxygen, 95% oxygen in your body. This patient was below 90% for 53 minutes. They were below 80% for 9 minutes. That's kind of hard to hold your breath that long. Then let's go back to what we were talking about. Look at the homocysteine level, the impact. What if this patient had factor V Leiden? What about the CRP, the C-reactive protein? What about the hematocrit? You see how this is all going to start to tie in. Let's go to the next. This shows the hypnogram. Occasionally I'll use a hypnogram. It's mainly for education, and I go to look at the right side where you see the green is the oxygen graph. The flatter it is, the better. This is very easy for patients to see when you're sitting here going, now see on this, on the right side, kind of towards the bottom where it's somewhat flat, and then you can turn around and see where above that it's elevated. You've got your spikes. And what's interesting is when your pulse rate increases, because your oxygen, when your oxygen level drops, your pulse rate's going to increase. So normally when you see a spike in the oxygen area, you're going to see it in the pulse rate. Let's go to the next. I don't really use this. It's just more of an expanded aspect of the hypnogram. We just wanted to put it up there, but I really never use that. Let's go to the next one. This is an interesting graph. It shows you the amount of time you're below, or what your oxygen level is and what you're below. Once again, I really don't use this one, but I wanted to let you know that it's there. You may decide to use it. It is very descriptive for the patient to see. This I use all the time. Look at the pulse rate at the bottom. When you're doing oximetry and you start titrating the jaw forward, you'll start to see changes in the pulse rate. So when you're looking at talking to a patient, you can say, look, I use the tap. So your X reference number turns here. We advance you. Look at what the difference was in your pulse rate. When you're looking at your oxygen levels up at the top, you're actually looking at the percentage of time. It's a visual for the patient to see. And so many patients are visual with it. That's one reason why I love the Profox program. Let's go to the next. And this is the one that I really like. I use this most all the time. So what we're looking at here is the CT90. You see on the upper right where it says time with SpO2 greater than 90%. You want that at 99% or more. Okay? So this is where it's visual. Patients can see it. The lowest and high, it's okay. I mean, I really don't go to there. I usually go to the CT90 because I say this is normal, and here's how you compare with normal. I also look at that valid testing time. You want to be above 4 hours. Let's go to the next. So we're going to do some case studies here. These reports were taken from my regular patients. Once again, I'm sorry, I wish I could have blown things up higher, but I couldn't. When you're looking at normal profiles, you're looking at the CT90, the desaturation indices, stable pulse rates, and pulse rate variation. The abnormal, you're going to be looking at low CT90s. Once again, I'm backwards. I look at things that you want to be above 90%, 99%, but in actuality, the definition is you don't want to be below it more than 1%. The elevated desaturation indices at 2, 3, and 4%, and the pulse rate variations. So when we're going to be looking at these, first thing you want to look at is, did they use it long enough? If they don't, I virtually always just have them redo it again, and I don't charge them for it. the valid record, the applied, oh, well, yeah, that's the second one. I'm sorry, I got mixed up here. You want to put down what strap you're using, the appliance position, how many half turns you're at, whether it's a Herbst or whatever. You want to make a notation of where that patient's jaw is at the time of the pulse ox. You then want to go ahead and check the valid testing time, 4 hours or more. You're then going to go from there to the CT90 to see if it's normal. And in that time, you're going to look at whether it's the amount of time below 90% oxygen. The oxygen saturation metrics are 2, 3, and 4%, which basically your norms are 5, 10, and 20. So a norm 3% would be 10, which is simulated of an AHI, which I think is high, but it just gives you a rough basis to go by. When I can get the normal desaturation indices, that's when I refer back to the physician, so long as the other aspects are normal. Then I look at the pulse rate and pulse rate variation. So basically, first, I'm going with the appliance jaw position. Secondly, I'm looking at the recording time to make sure it's valid. Then I go to the CT90. Then I go to the desaturation indices. And then I go to the resting pulse rate and pulse rate variation. Let's go to the next. So this is a normal case. And when we look at it, you're going to go, the patient was 6 hours and 4 minutes of valid testing times. Sometimes you'll see a recording time of 8 hours and a valid testing time of 5 hours. And this is where the patient goes, well, it came off, but once again, you've got valid testing time. It won't, these are pretty sharp instruments. If it's come off, you're not going to get the valid testing time. So we go valid testing time. We look at the CT90 at 6 hours, 4 minutes, and 32 seconds. It's 100%. Then you look at the desaturation indices. 2, 3, and 4 is 4.3, 0.2, and 0. We did a pretty good job. Here again, remember I mentioned the 12.2 times per hour. So when you're below 12.2 times per hour at the 2%, effectively there's no disease. Now here again, that doesn't mean you have analytics, which this is, and then you've got the subjective aspect. You can have, I got a patient right now where analytics are beautiful, but he goes, I'm still tired. Well, this is where you have to look into idiopathic hypersomnolence, which personally I think is the lower the occlusion. Most occlusions are at the oropharyngeal area by the uvula. You can go velopharyngeal a little higher, but the lower you start to get towards the hypopharyngeal area down near the vocal cords, to me, that's where you're going to start getting more of an idiopathic scenario. Patients will ask me why, and I'll say, well, look, your airway is unsupported. So really, when we're looking at your airway, yes, these numbers are correct, but your occlusion, I had a lady today telling me where she thought her airway occluded. And I said, well, look, the occlusion can be high, low, medium, velopharyngeal, oropharyngeal, or hypopharyngeal. It can be circumferential, front to back, side to side, full, partial. Then you're dealing with tongue level. There's so many wheels in motion that we're doing the analytics. And so the point is, that's my job to get the airway open. Okay. Other issues can come up. It could be idiopathic. It could be their medication. Uh, it's not just what we're dealing with here. This is a piece of it and a major piece. We can go to the next one. Hypnogram, look at that right side, how nice and smooth that is. That's beautiful. That's a normal oxygen level. And yes, there's spikes on the left side, but you saw it was, once again, for whatever reason, I can't answer that, but if you'll notice where the spikes are, the oxygen level has not changed. Let's go to the next. This is another normal case. We go 8 hours of valid testing time. We go CT90 at 99.9. So we have the DSATs at 0.5, 1.8, 6.7. We're below 12.2. Let's go to the next. This was the hypnogram or the other page, which I love. Now, mind you, that's as normal as can be, but it's at 3:09 and 21 seconds in the morning, they stop breathing for 1 minute 23 seconds. Pulse rate went up 18 points, but you don't really see that often in there. So when I'm doing a consultation with a patient, particularly when I'm trying to get them to consider combination therapy, I'll say, well, look, at 3 minutes, 9 seconds, and 21 seconds, you stop breathing at X number of minutes. They see it, and that makes a huge difference. And you'll see this in some of the other following reports. Let's go to the next. This is another normal one. Oh, you went back. You need to go forward.
I didn't go back.
Oh, go back to where you were then. It's just me. All right. Mea culpa. On this case, it's normal, very normal. Okay. Now we go valid testing time. We have 100%. Uh, got normal DSATs. That's on 710. Yeah, go to the next one. So this is the same one. But even so, it's normal. Look at that. The patient at 312, at 11:03 and 12 seconds. Well, what was it? 11 or 10:59 and 46 seconds. Stop breathing for 2 minutes and 47 seconds. Most patients will fall out of the chair, excuse me, and go, oh my God. I go, yeah, I guess you're a world record breath holder. Remember, what we're doing with oral appliance therapy is we're changing apneic events into hypopneic events, maintaining a normal CT90 oxygen level above 90%, 99% of the time or more, maintaining a normal pulse rate, and not having excessive daytime sleepiness. So is this totally perfect? No. But at the time, as I have here, he stopped breathing for 2 minutes and 51 seconds. His oxygen dropped to 90. It's acceptable. And his pulse rate only went up 4 points. Actually, a lot of physicians that I deal with, unless it's below 90, physicians couldn't care less. In the dental world, we do care less. So it's just to show you that you can have all normalcy, but the time of stopping breathing can still be there. Okay, next one. So don't you love this CT90? So we have a normal valid testing time of 7 hours, over 7 hours. Their CT90 is 36%. They might as well be living on top of Pikes Peak as far as the lack of oxygen. So they're going to have a higher hematocrit, thicker blood, high homocysteine level more than likely. And if this patient has a history of TIAs or heart attack or cardiac stents or factor V Leiden or any of those, I'm getting them on combination therapy. It's kind of like I'll tell my patients, we need to throw all the mud up against that garage wall yesterday. Look at the desaturation indices, 86, 88, 93. I'm surprised the guy's alive. Now take a look. Let's go to the next one and look at the hypnogram.
Back up on this one on your total number of events less than 3 minutes. How is that even possible?
Don't ask me. I just work here. It's amazing. It's amazing to see people hold it, with no change and they're not breathing. Of course, that can get into the Bohr effect also, where I've had patients be able to not breathe for quite a long time. So, but yes, it is interesting. Now look at his hypnogram. Gee, think that's normal? I mean, literally, the guy's a walking stroke risk. This is where I sit down for combination therapy. You may be able to help them. Now, mind you, this is with treatment with the appliance. So you see how bad they are. This is where we get them into combo therapy. And I've treated patients with HIs up to 140 We just had one a year ago, HI of 135, we got him to 7, but he still had a high pulse rate variation and resting pulse rate.
I know
Uh,
Eric doesn't want you to talk about this right now, but we're going to need, all of us are going to need you to explain how do we go about combo therapy if we've already put them into an appliance.
it's well, and that's our next study club.
Okay, good.
Yeah,
All
it's
right,
going to be
because
on
you're talking
difficult.
about it.
It's on difficult cases. And for those that we've got some exciting things coming down the line that Eric can talk to you about. But when you take my seminar in office, I'll introduce you to this. We'll probably have a video or a separate course on actually how to do this. But we just had a patient 6 weeks ago with an HI of 84. We got her, or 82. Overnight, she went to 4. She's on cloud 9. So this is something that can really be an adjunct to your practice and put you head and shoulders above anyone else in your area. This is another abnormal hypnogram in a combo case right off the bat. So I just thought I'd show you what an abnormal. Once again, you wonder if how they're still alive. The body is very accommodative. So in this case, we're looking at valid testing time is normal. We have a CT90 of 87%, normal desaturation indices. All right. Now, this patient is on combo therapy. Okay. Now, if the patient wasn't on combo therapy, when you have a low CT90, you have to consider, does the patient have lung cancer, asthma, COPD, interstitial disease? I'm a Navy vet, Vietnam era, but a lot of the men and women that were stationed in Iraq, Afghanistan, even Vietnam were around burn pits. And you're breathing all that crap. So at the next meeting, I'll go over some stuff that I put most all my veterans on. It's an oral chelation method. It's dirt in a capsule, but it works. Now, two things. If this was a regular patient who's actually on combo therapy like this, and I'll go over EPR when we start discussing CPAPs, then I would refer the patient back to the physician to have possibly ancillary oxygen put through their CPAP machine. Okay? If this is a normal case, go back for a second. If this is just a plain oral appliance case, I would automatically at that 87 tell them, let's repeat this and just make sure there wasn't an error. And most of the time you see this where all the other parameters are normal. It's for some reason, and don't ask me why, it could be variability, but they come back normal. And then that's one reason why you keep them on recall, to keep an eye on patients. That's okay. You can go ahead next. This was tied to the previous one with what we just talked about. Look at that. Normal pulse rate variation, normal pulse rates. So, but their oxygen level is low. Here again, did they smoke? And what's also interesting is people never ask about marijuana. Marijuana burns at a higher temperature. It'll cause even more damage than what a smoker would have. So if this was combo case, I talked to the physician about ancillary oxygen. If someone has an issue or a question, call me. If it's someone who's just on the appliance, I'd repeat the test, see what it is. And if it is still low, then I talk to them about combo therapy. In most all of those cases, we get completely controlled. Let's go to the next. Now, this is desaturation. It can be quite, yeah, this is where I was showing you about the desaturate, the time frame, 2 minutes 42, 2 minutes and 51. And what's really crazy with this is their pulse rate and pulse rate variation is normal. So you will see these things, but all the other parameters are normal. And I just go with the flow because the oxygen, your job to get the oxygen level. Or as one of my patients came in, first thing he said is, Doc, it's your job to keep me on this side of the dirt. Let's go to the next. All right, so this is where we've got a valid testing time of 8 minutes and 14 seconds, normal CT90 at 99.6. Desaturation indices look terrific, okay? You're below 10 for the 3%, and you're below 12.2 on the 2%. Now let's look at the other one because I'm sure you're going, why is this abnormal? Let's go to the next one. And look at their resting pulse rate, 100 to 108, 79 to 90, 91, 98, 101. Why didn't the person just go run around the block? You're looking at a period of 8 seconds. There at the very bottom, their pulse rate went up 34 points. Over a period of 2 minutes and 56 seconds, what, 30 points? This is where you're looking at and say this is a young person, this is a precursor for AFib. You need to continue to titrate. And if I've had one patient where even with the titrate, no matter what we did with the titration, we couldn't get everything was normal. Guy was in perfect shape. That pulse rate was still high. We put him on combo therapy. We pulled everything to normal. The only thing is he's about a 40-year-old guy in perfect shape who's single. He doesn't want to go to bed looking, with the interface. That's up to him. But you can have normalcy, and then this is a classic example of abnormalcy. Let's go to the next. This is another case, normal test, valid testing time, 4 hours, 43 seconds, normal CT, normal desaturation indices, little high normal on their 2%, but still normal. Go to the next. Look at the pulse rate, 62 to 85, 76 to 94. That's kind of at this point, I would continue to titrate. If you're doing a tap, I'd say come out 2 to 3 half turns. Then I would repeat it and let's see what they do. Okay, I think I have the one after we titrated. So we went ahead, wait, no, this is a different one here. You've got a CT90 of, no, you're good, you're good. Let's go back. This is one with a valid testing time of, what is that, 8 hours, 4 hours and 25 minutes. CT90 is 74. You've got elevated desaturation indices. This is one where I would consider having them, advance more. Now the desats are high normal. So go, and this is with, well, go ahead to the next one here. But now look at the pulse rate and pulse rate variation. All in the 90s. You see the, variation big time in areas. This is where I would continue to titrate to see if we can get an improvement. And if not, then you consider combination therapy. Let's go ahead and go to the next. So in this case, good valid testing time, DSATs, your CT90 is normal. Your DSAT should be 5, 10, and 20. He's at 4.7, 9.7. I would advance a little more, 2 or 3 half turns and repeat. If they can't come any farther forward, this is one where you inform them that, look, we pretty much got you taken care of, depending on subjective symptoms also. Sometimes you just can't bring the jaw forward due to discomfort. This is another reason why when you've got an appliance that jumps 0.5 millimeter, that's a big distance in the mouth. And a lot of these patients say, I could bring this patient 1/4 millimeter forward a little more with comfort and get a little bit better aspect with this possibly. Or when they come back for a 6-month recall and the muscles have had time to stretch, that's where you might be able to pick up with a little more titration. Let's go ahead and go. And then here again, look at the pulse rate variation. 50 to 79, 54 to 74. This is why, one, the DSAT's slightly higher on its own, I would continue, but when you look at the pulse rate, that makes a difference. Let's go with the next. This one's blurry and I apologize. The beauty with the TAP appliance is that the upper adjustment plate. I was one of 5, I was one of 5 offices in the US that used to actually manufacture the TAP 1 and 2 in office. We had 24-hour turnaround. So I take them apart and put them back together. And anyone who takes my in-house in-office seminar, I show you how to do all that. So with this patient, we took a normal, an appropriate bite, but fairly flexible. So I went ahead and I moved the upper plate 3 millimeters forward, which is 12 half turns because of that CT90 at 79%. He had a good valid testing time, and the DSATs are normal except for a little high in the 2%. Go ahead and go to the next. And this is by moving him forward. He went from 74 to 96, and the DSATs are totally normal. So basically he's now at 15 half turns, whereas otherwise he would have been at 27. So the beauty with the tap is that you can manipulate it, move it around, adjust it. I actually had one patient before we got his oximeter readings normal. He was we moved him from an end-on position an inch and a half forward. Somebody was taking my seminar at the time. He was going nuts. He pulled his camera out. He couldn't believe it. Now that was several years ago, and the patient is right now having some cognitive factors. He's a little older than I am, a little bit of Alzheimer's setting in, and we have him probably about 80% control, but we can't pull him any farther forward. For that type of a case, I used a tap one because it has really an extended capability for a movement. Let's go next. If anybody has some questions, I'm more than happy. I hope I didn't move through things too fast. And I'm always available if someone has a question with a patient down the road. You can always send over an oximeter report, and Jennifer can tell you. I'll spend a few minutes with you going over it.
So we can right now, if you want, you're set up so you can unmute yourself. If you have any questions,
Oh,
you can chat, put them in the chat, or you can just unmute yourself and just ask your question. So feel free. We'll open this up for a few minutes to do that. Not everybody at once, though. Okay.
it's pretty heavy to be going through all of these like this.
Something I'd say is that we've got some negotiated rates with the manufacturers, and so if you're interested in getting the 3150 or the Profox, let us know and we can get you our discounts on those.